Okay, next topic for discussion is gout. Patients with gout are going to have an inflammatory presentation of the great toe with redness, swelling, pain, and tenderness of acute onset. Now remember, this is known as podagra. Now podagra is actually the inflammatory presentation of the MTP joint, the metatarsal phalangeal joint, and it's classically the first place where gout presents, okay? If this patient has the inflammatory presentation above, our best initial test is actually going to be arthrocentesis. If they ask you the most accurate test, it's going to be examination of joint fluid by polarized light examination. So our best initial is arthrocentesis. The fluid we get from the arthrocentesis, we're going to put it under polarized light examination, and that's going to be our most accurate test. If on polarized light examination we get negative birefringence, we've made our diagnosis of gout. Now, there's certain things that gout's associated with. Obesity is associated with gout. Excess alcohol intake, such as binge drinking, is associated with gout. Thiazide diuretics are associated with gout. Nicotinic acid is associated with gout. So if patients are on any of these drugs or they're predisposed to any of these things, it's something that you want to keep in your differential. Now, it's an easy diagnosis to make clinically. So we've done arthrocentesis, we've examined it under polarized light, we've seen negative birefringence, so we've made our diagnosis of gout. Once we've made our diagnosis, what's the first thing we want to do? We want to give them an NSAID in the acute scenario, okay? Indomethacin is a drug of choice, and if they have an insufficient response to NSAIDs, we can use corticosteroids, only in the acute attack, and we're going to give it PO. Remember, the route of administration is quite important on step 3, okay? And only if there's a single joint affected can we give intra-articular corticosteroids, but PO corticosteroids is definitely better than intra-articular injection, and it's definitely preferred. So the only time we're going to give corticosteroids in an acute attack PO is if there's an insufficient response to NSAIDs, and we can only give a single intra-articular injection in a single joint. Once we've treated the patient's acute attack, we want to, we have a goal in management, okay? And our goal in management is a uric acid level less than 6, okay? And if the patient has something known as tophi, our uric acid goal in management is actually less than 5. Now, tophi are actually punched out lesions we're going to see on the x-ray. And if we see these tophi on the x-ray, these punched out lesions with a preserved joint space, we're going to have a goal of less than 5, uric acid level less than 5. Now, we've managed the patient in the acute case, and we can give colchicine actually within the first 24 hours after the initial attack, and we've managed the patient acutely for gout. The next step we want to do is long-term therapy for gout. And what we want to do is measure the 24-hour urine uric acid to know what type of gout this is. And based on what type of gout this is, it's going to distinguish what drug we're going to give these patients long-term for gout. Now, if the patient has a urinary excretion over 800 milligrams per day on an unrestricted diet, this patient is an overproducer. And overproducers of uric acid get allopurinol long-term for prevention. Now, a question they commonly ask on the test is, a patient developed acute gouty arthritis while they were on allopurinol. Remember, one of the choices may be DC allopurinol. We don't want to discontinue allopurinol, okay? We actually want to add NSAIDs until the flare-up resolves. So patient is managed for gout and they're put on allopurinol, and then they develop acute gouty arthritis while on allopurinol. We want to add NSAIDs until the flare-up resolves, which makes sense because acute gout, remember our treatment, NSAIDs, right? So we're just going to keep them on the allopurinol and we're going to add NSAIDs until the flare-up resolves. Times that we give allopurinol for prophylaxis is nephrolithiasis, tophi, renal insufficiency, and recurrent attacks of gout. Okay, and we want to do preventative measures as well, because remember I said that alcohol binge drinking can cause gout and so can obesity. So obviously weight loss and avoidance of alcohol are preventative measures for gout. And if the patient has less than 800 milligrams per day, if they're excreting less than 800 milligrams per day, They're known as under-excretors. And these patients, we want to give probenecid for prevention. Okay? So remember, in gout, patient comes in with a presentation of redness, swelling, pain of acute onset. We're going to think gout in our differential. We're going to do an arthrocentesis. We're going to take the fluid from the arthrocentesis. We're going to put it on polarized light examination, which is our most accurate test. Our best initial is the arthrocentesis. We see negative birefringence. We've made our diagnosis of gout. What are we going to do first? We're going to give him an NSAID. The best drug is indomethacin. If an insufficient response to NSAID, we're going to give PO corticosteroids. And if a single joint is affected, we can give intra-articular corticosteroids. And we want to get a uric acid level less than 6. And if there's tophi present on X-ray, which are these punched out lesions, we can give. We want to have a level less than 5. Our goal in management is going to be less than 5 if there's tophi present. After that, our next step is to measure 24-hour urine uric acid. If it's over 800, overproduction, we're going to give allopurinol. If it's under 800, it's an under-excretor, we're going to give probenecid. And remember, if a patient has acute gouty arthritis while they're on allopurinol, we don't discontinue allopurinol. We just add an NSAID until the flare-up resolves. And we're going to give allopurinol as prophylaxis for the following cases: nephrolithiasis, tophi, renal insufficiency, and recurrent attacks. And we want to give them preventative measures such as weight loss and avoidance of alcohol as well. Now, if the patient for some reason comes in with positive birefringence, which won't happen in this case usually, because if it happens on the great toe, it's going to be negative birefringence and gout. But sometimes they ask you pseudo-gout. Pseudo-gout is usually actually going to affect the knees and the wrists, not the toes. But they're going to be positively birefringent, and what we have to remember, the best initial therapy is the same for pseudo-gout as it is for gout, and it's going to be NSAIDs. And that's pretty much what we have to remember. They may ask you the side effect of certain drugs, and colchicine can actually cause nausea and diarrhea. They could test you on that on the test. Patient presented with nausea and diarrhea after given a gout medication, and it can also cause bone marrow suppression, but it is useful within the first 24 hours of the initial attack after indomethacin. And allopurinol is another one they may ask you the side effects of, and it can actually cause a rash, allergic interstitial nephritis, and hemolysis. And this is pretty much everything we need to know for gout. Good luck, guys.